Thank you, Tim, and I agree that Sarah nicely introduced the next topic, and we should be able to reduce those early and 1 year, actually, secondary procedures by having perfect technology. Thanks, Bentley, for organizing this symposium, and thanks to all of you being awake this morning after the party yesterday evening. I appreciate that. So now I'm going to talk about the FEVAR revolution. What has completely changed our world in the past couple of years. Those are my disclosures and obviously a conflict with Bentley. Why have we switched from open, aggressive surgery to minimal, invasive endovascular surgery? How did we do that? How did we come up with performing those more and more complex procedures in the endo world? Well, first, there was the main revolution was the 3D imaging arriving into our OR, helping us to select the appropriate patient, to plan the procedures, to guide us through a procedure, and then to assess with cone beam CT that Andy showed us nicely. So this is the hybrid room. This is the fusion guidance, obviously helping us to nicely position the graft and get access to the target vessel. Another example here in the arch and accessing the left renal on the right side. Now, the second revolution was steerable sheaths. I mean, that was a complete game changer when we started to do those procedures with a steerable sheath. Suddenly, the radiation and the time to perform those procedures significantly decreased. We started to use those selectively only for complex target vessels, such as the celiac trunk, which usually is the most difficult target vessel to access. So you can see steerable sheath here helping us to go through a celiac trunk, advancing the bridging stent, and then keeping that target vessel open. Another example here of the steerable sheath under fusion guidance. You see the stent, which is a BeGraft, advance into this target vessel, and it gives you a perfect stability to inflate the bridging stent and then go back in the target vessel before performing the flaring. There you are. Now, the third revolution is having dedicated bridging stent to perform those procedures. And we recently had the CE approval of the BeGraft peripheral, which is the second generation of BeGraft that was released in 2015, so quite a long time ago. And so we have considerable experience in FEVAR, and we have a lot of literature focusing on the outcomes, midterm and long-term outcomes of those specific bridging stent platform in fenestrated endografts. So those are the papers that have been published, and more recently, there's been the multicentric prospective German trial that showed fantastic data to obtain the CE mark. And that platform, the BeGraft, is now pre-mounted on a stepped balloon, and it's called the BeFlared. And you can see a specific focus on that balloon with a couple of markers, and especially a fenestration marker that has been added. I'll show you in the next slide. But the stent is the same as the BeGraft peripheral. The one that I just showed you has huge clinical background. Now, this is a closer view on the BeFlared, and what you can see here is that there's this fenestration marker. So now you know exactly how to position your bridging stent when you're performing a fenestrated endograft. When we had this discussion, when doing a relining a failed EVAR, there's so much metal inside. When working, Michele was talking about in a narrow lumen, you don't exactly know how much is protruding in the aortic lumen. So now you will be able to really precisely position this marker at the level of the fenestration, and if you want more or less stent protruding in the aortic lumen, this is something that you will be able to do. And obviously, you understand that by a single inflation of the balloon, you implant the stent in the target vessel and flare the stent. So you don't need to go back and forth in the target vessel to perform the flaring, which obviously is a main difference. Now, if you look at the various options available, the stent is available in 5 to 9 millimeter diameters in the target vessel, and the flaring is 8 millimeter for the 5 and 6 millimeter platform going into the renal artery, which usually is a 6 millimeter fenestration. 10 millimeter flaring for 7 and 8, and 11 millimeter flaring for the 9 millimeter stent. So adapted to the 8 millimeter fenestrations that we currently use for the visceral fenestrations. Now, if you look at the various stents available, the various BeFlared, you will see that the nominal pressure and the rate burst pressure is identical for all those stents. And so then you can play with the pressure to adapt to your patient's specific anatomy, but playing between 6 and 12 to perfectly adapt to your patient's target vessel anatomy. Now, the BeFlared history, there's a lot of background behind releasing that new platform. There's a lot of bench testing. There's a lot of CFD. There's a lot of clinical data that I showed you. And this is how we came up with the conclusion that the current BeFlared is actually the perfect bridging stent. And if we could make it, if we could crimp it on a balloon that would flare it at the same time, this would be obviously a game changer. So when we had developed first this stent, we performed animal trials, and this was performed by my friend Dominique Fabre on those animal models where we created some pararenal aneurysms, and you can see we implanted fenestrated endograft in those pararenal aneurysms, and this was the first animal study. And then what we did is we also tested the BeFlared in a lot of 3D printed aortas with various target vessel anatomies, and we obviously pushed the envelope and tried it in very challenging target vessel. And so this has been all the testing on the various 3D prints, and we tested a huge number of those BeFlared, and this helped us to understand how we could use, and we really saw that there was a huge clinical benefit using this platform, a single inflation, again, implanting the stent and doing the flaring. So we now have the first dedicated bridging stent for FEVAR. The EPTA Feed 200 micro cover is really proved to have perfect long-term outcomes. You have this 2-in-1 design. You inflate the balloon and flare during the same step. And you have this specific fenestration marker that helps you to position very accurately your stent during the procedure. We did the first in man 2 weeks ago. This was a regular FEVAR patient, the 4-fen endograft for that patient with a juxtarenal aneurysm. You can see here that the left renal was actually perfusing an atrophic left kidney, so the left renal main trunk was really short, so we didn't use a BeFlared for this one, but we implanted a BeFlared in the right renal and the 2 visceral arteries. Those are the BeFlared we selected, 727 for the celiac trunk and SMA, and 627 for the right renal artery. A couple of videos from the procedure. Please focus on that fenestration marker that we're positioning at the level of the fenestration, so we know exactly what is protruding out of the aortic lumen, inflating, and you can see the flaring is on both sides of the marker. You have a couple of millimeters inside, a couple of millimeters outside, so the beginning of the target vessel also benefits from that flaring, and you get a perfect seal into the target vessel here, the celiac trunk. Now we're working on the SMA now. Again, look at the fenestration marker that is positioned at the level of the SMA fenestration, inflation of the balloon, and you see the flaring that also protrudes in the origin of the SMA. And see how the steerable sheaths just jumps after into your target vessel. It's very easy. Remember that at this step, usually we sometimes had to struggle to get the sheath back in the target vessel. And then the right renal artery, again, straightforward. This procedure lasted 70 minutes skin to skin for a 4-fen, which I had never performed before. Steerable sheath, fusion guidance, and the FEVAR. And you can see this selective angio and the post-op CT. Now, we checked on the post-op CT the outcomes and looked specifically at those 3 BeFlared stents, and you can see you have here 5 mm protruding in the aortic lumen. You have a perfect flare. This is not something we would achieve with coming back with another balloon, because to get the flare at the top is always quite challenging. Celiac trunk is here. The SMA, same results. We have 4.7 mm protruding and a perfect flare you can see here. And finally, this right renal artery with a perfect flare also and 5 mm protruding. Jonas, so we have a lot of physicians from Germany, from Italy, from Denmark. Tim, you've tried this platform, Andrew Holden in New Zealand. So we are getting more and more experience and feedback from those experts, and everyone is currently really very impressed by this platform. So the FEVAR revolution, it's a multidisciplinary adventure. I want to really say that it has been a shared experience and a work between a physician and the industry R&D, and that was a fantastic adventure. The BeFlared is a game changer in our practice. It's faster, it's safer, you reduce radiation exposure, and most of all, you reduce technical issues. This is really the step of the procedure when you get in trouble. It's when you go back and forth into your target vessel to do the flaring. Now it's not anymore an issue, and I think it's going to be associated to echo what Sarah was saying with less secondary procedure and better outcomes for our patients. So thank you very much. Thank you, Bentley, for organizing this symposium, and happy to answer any question.
Thank you, Stéphan. Fantastic overview. I've had the privilege of trying the stent. You know, I said yesterday, 26 years since the first fenestrated graft. There have been a few pivotal moments, and I had high expectations for the stents, but they were actually vastly exceeded, I must confess. It's very nice. One thing you didn't mention is the stent retention of this stent on the balloon. So any comments? In my very brief experience, I've done 3 cases. It sits very, very tight on the balloon. You don't even have to put the sheath anymore out in the target vessel. Any comments on that?
No, I think that having the flared stent crimped, the balloon crimped on the stepped balloon makes it a very stable platform. And obviously, there's no question mark regarding pushing the stent through tortuous anatomy so far. And I'm talking about maybe 15, 20 cases performed worldwide. It seems that what you're saying is actually one of the other benefits, so I can only echo what you're saying.
Stéphan, thanks for leading the way. 2 questions. One, just kind of technical. Has the flaring balloon changed the profile? That is, do you need now larger French size? And the second question is, looking 5 years, 10 years from now, will there be an inventory of one bridging stent graft for branches and fenestrations, or do you see them always having difficult mechanical property needs?
So currently, with the current technology, I think we need 2 different platforms, one for fenestrated and one for branch. And we've shown with we saw with Michele's presentation that it's not exactly the same configuration. Now, your first question was? Oh yeah, the French size. Yeah, it actually increases by 1 French the profile. But you know, we've been using 7 French steerable sheaths for all those cases, so they're all 7 French compatible, except the much larger diameter.
Michele.
So, Stéphan, one of the problems when we work with balloon expandable stent in fenestrated graft is the foreshortening of the flaring inside the graft. Could you please describe a little bit better the characteristics of this stent in these terms?
So you've seen, and it's a very important question, and I should have focused more when I show you the slide with the 3 markers with the balloon inflated. You see that the foreshortening is the distance between the proximal and fenestration marker is 7 millimeters. But once you inflate, you lose 2 millimeters. So you know that exactly. Okay. So you know that the distance once it's inflated from the fenestration marker to the tip of the stent is 5 millimeters, and this is what I wanted to show on the post-op CT, showing that it's actually very precise the length of the stent protruding in the aortic lumen. And then you can play with it. You can decide, you know, how you want.
So if for some reasons you want a larger flare or you want a foreshortening, you can exchange a balloon and decide to have more flaring and shortening a little bit.
Yeah, and also what you can do is actually that marker push it more into the target vessel or less. So you actually know what you're doing compared to what we were doing previously.
Right. Yeah, and the technical point here, Stéphan, if the target vessel has a very acute angle as the celiac trunk or the SMA, you probably want to have it a little bit more outside because they tilt a little bit, and then you may not have a seal. And any experience on that one so far?
So we've tried this new platform with both steerable sheaths and non-steerable sheaths. What we've learned is to really precisely control the positioning of the stent, especially in those downward target vessel. You have to inflate slowly the balloon, and then it really doesn't move, and you get the perfect flare. At the beginning, I was doing it the way I used to do, quite quickly. Now we've learned that by slowly inflating it, it just doesn't move a millimeter.
Can't wait to get my hands on this one.
Yeah, it's good. Well, I think we're out of time. Thank you very much, Stéphan. Elegant as always. Thank you, Bentley, for hosting the symposium. And we're going to move
Thank you.
forward
Thank you
in
so
the
much.
session. Hence.